wondered if you could give us your opinion of treatment as prevention from the point of view of value.
Well, I think, very honestly, this is an area where I think everyone's opinion is as good as the next. So what we can really do is just discuss things, because I don't think any of us knows how it will unfold.
First, I asked about treatment as prevention.
Yeah.
And value.
I mean, I think there's no question that if it can be done as effectively as it was done in Malawi, and if you can achieve complete viral suppression, it's going to be pretty good. And we saw that. The difficulties you may know is that only 30% of people in the US in this country on HIV treatment are virally suppressed. So in the real world in the US, we're not achieving very high levels of viral
30%.
suppression. Yes, those are the figures that we
And
know.
that's because of non-compliance?
Principally erratic compliance, and sometimes it may be slowness to detect that regimens are no longer working, etc. That's a key issue. I think the other issue, and there have been some good papers recently, is how important a role acute infection, early transmitters play in an epidemic, because those are not people that we can pick up. My own view is that it's likely to have some effect, but it may not be large enough to make a decision an easy one. I think that in the real world it may be somewhere between 10 to 35% effective, and then that raises your question about whether it's cost effective. And I guess the theme of the Washington conference here is going to be important. Realistically, the way you could justify treatment for prevention would be if we thought we could end the epidemic, was really change the trajectory of the epidemic. Yeah, and that's definitely going to be a theme of the Washington conference. And I guess doing that, though, would almost be tantamount to mounting another PEPFAR, and one has to ask about whether there's the global appetite to do it. What do other people think? This is truly an area where we're all speculating.
Did anyone ask about the Truvada
Yeah.
pitch?
Yeah.
Okay. To the FDA, I guess that's coming up tomorrow, right?
Yes,
Is it?
tomorrow.
Yeah, PrEP has to be even harder than treatment for prevention, don't you think?
I do, but I mean, it'd be interesting to hear
Yeah.
other folks' thoughts.
Yeah, but I think one of the reasons, HIV has been stabilized in a lot of countries and also population. But for most at-risk population, I still see the HIV epidemic continues to increase. And among MSM in Africa, you can see that 4 to 10 times, and in some countries you can see 10 times higher than the general population.
Yeah.
So I think the question is where the condoms work, and
No, of
also
course.
behavioral communication works for those populations.
Yeah.
So maybe ARV-based intervention should be the next generation. I'm not sure about that.
Targeted treatment for prevention. Yeah.
Well, that's kind of what I wanted to ask about, was your thoughts on the balance between these sort of older interventions that have a lot of evidence behind them but have never really been scaled up versus some of these newer ones like treatment as prevention and Truvada that sound great on paper but maybe would still face the same operational challenges in terms of scaling them up. I mean, are we always looking for the next new thing rather than should we be focusing more on scaling up what we already know works?
Yeah, I agree. I guess I'd make the old distinction between concentrated and generalized epidemics, and if you use India as an example of a concentrated epidemic, if through low-cost, low-tech targeted interventions that PSI has been a big part of in Maharashtra and elsewhere, we've managed to reduce HIV by 70%, and the decline seems to be continuing and deepening. India probably doesn't think it needs to use treatment for prevention to strengthen its existing programs. And I think we would all agree that well-done targeted programs for sex workers, for men who have sex with men, and drug users work. So we do have some simple things that we're not applying. The real challenge seems to me to be the generalized epidemics, in particular of Eastern and Southern Africa, where probably the best evidence base we have is for male circumcision. And we know that male circumcision can make quite a difference, but it's not going to do it on its own. Best case is still going to be, 20 to 40% in the real world reduction in HIV if we can achieve levels that are much higher than anyone except Kenya has achieved. But then I agree with you. If we haven't been able to mount basic targeted interventions and concentrated evidence, if we haven't been able to mount effective programs, how are we going to be able to do something infinitely more complex such as treatment for prevention? I think that where there's going to be common ground, and that's probably the area of agreement that we all want to build on, is realistically, I think what we're likely to be able to do is keep increasing the inception point, the threshold point at which people begin treatment. In South Africa yesterday, they're telling us they're still barely at 100, they're at about 108. This is the CD4 level. So realistically, if we just keep working incrementally at raising that level, Brazil, for example, is at 250, 280, which is really impressive. That may be an area of common ground between treatment for health outcomes and treatment for prevention that we can all agree on. So my own view is practically that's probably where the efforts are going to be concentrated, with some effort to target treatment for prevention more towards pregnant women, more towards TB patients, etc. But I'm speaking too much, and this is a speculative field, so what do you people think? What are the rest of the views?
It's just building on, keeping increasing the threshold for early initiation of treatment. The WHO's guidelines state that you should initiate treatment once CD4 cell count drops below 350. So 108 in South Africa, generalized epidemic is actually very, very low. However, there seems to be a huge missed opportunity between the 2 million or so people that we get tested each year, just as PSI alone, in about 30 or so countries, and how many of those actually make it to an early CD4. And on the side of donors, a little bit of a disconnect between point-of-care diagnostics, including CD4s, and linking those people to care more effectively, because you need to get that baseline CD4 count. We've tried to advocate for this with a number of donors. CDC is probably, they get it, so they're willing to fund CD4s. That's an area that we are thinking of strengthening in our new strategy. Would that be the right way to go? And anything else that we should be thinking of in that?
What I really like about that point is, I think in terms of how we position and how we market aids to funders in future, I don't think that we've stressed enough the extent or the gains of innovation. I think you could really say there are few fields where we've innovated as much as HIV. And if you're just to take 4 or 5 small examples, we have more drugs to treat HIV than every other retrovirus in history combined. We've driven the cost of treatment from $15,000 to $300 or $400 in less than a decade. We've expanded coverage 25-fold. It's the largest expansion of health services anywhere in history. We now have devices that you can use for circumcision that don't require nurses, don't require sterile environments, don't require anesthesia, don't require time off work, and don't cost very much. And if you've seen some of the stuff that's coming out of places like the Burnet Institute in Australia, we may be quite close to $1 point of care CD4 and viral load machines. So I think one of the ways in which we can present HIV to funders in a way that doesn't just make it look like an endless mortgage is to stress the incredible innovation and efficiency gains that we've made. And so I agree with your point substantively, and I also think it's how we need to keep presenting.